lack of sleep. What is the definition of sleep? So the simple thing is to say it's a complex, reversible, because obviously we wake up every morning, neurobiological state, because it happens in the brain, characterized by closed eyes. I'm sure none of us can, even if we try, fall asleep with open eyes. Behavioral quiescence, so we're very quiet, we don't do anything at that time, and we are disengaged from one's environment. And there's a longer definition. But it's impossible to get a sleep definition which satisfies everyone. And this we've known for a very long time. And there have been repeated attempts to give you a good definition of sleep which satisfies everyone. And the thing is, sleep occurs in so many different areas of medicine and outside medicine that a single definition never keeps anyone happy. So why do we need to sleep? First of all, we need some period of inactivity. And that's very, very important. And apparently in prehistoric times when man was evolving, you had a time when somebody needed to stay awake and somebody needed to stay asleep. And especially at night when you went to sleep and didn't go around doing things, animals and enemies would not attack you. And that's also why we have some people who are at their best early in the morning and others who go to bed very late at night, because this ensures that in a tribe or in a community you have some people who are alert during the day and some people who are alert at night. And currently we use the term larks, who are getting up early in the morning, very active in the morning, and owls who like to do their best work late at night. So this is all a part of our evolution. The second very important function of sleep is all our systems get restored during sleep, physical as well as mental. The third is we need to conserve energy. We're awake all the time, we'll be burning energy, and we know that energy depletion slows down and energy use slows down when we sleep. And very, very importantly, new connections between neurons are formed during deep sleep, especially during REM sleep, where useless memories are taken out and good memories are strengthened. And that's something for students to remember. All of us make the mistake of putting in many, many hours of sleep at night just before an exam. And that's the worst thing to do, because everything you study, if it has to be firmed up and form a part of your memory which you can use in the examination, is not put into deep memory unless you get a good night's sleep. And that's something that should be taught to students from the day one when they start their medicine or dentistry program. So we have a lot of functions of sleep. I'm not going to go into this because essentially it says the same, but I'm going to remind you of REM, where memory consolidation, rapid eye movement sleep, memory consolidation occurs, and in the child, much more REM sleep. This is when new neural connections are formed and learning happens. So all of us sleep, but animals also sleep, and it varies from animal to animal. And you can see that the carnivores spend a lot of sleep with half the brain at a time. The dolphin sleeps with one half of the brain. The other half is still active. Why? Because it has to surface to the surface of the water. Remember that dolphins are mammals. So unless they can surface, they cannot breathe, they drown. So periodically, one half of the brain brings them up, they breathe, they go back down. Similarly, birds. If a bird goes into deep sleep with both the hemispheres, it will fall off its perch and be a prey to animals. So it stays, one half of the brain keeps it awake, holding on to its perch or the branch, and then the other half of the brain has a chance to rest, and they keep exchanging. This is called hemispheric slow wave sleep. So when you look at sleep, there's a cycle. We think of it as a single phase, but actually we go through two major stages, what is called non-REM sleep and REM sleep. REM standing for rapid eye movements. And you sit and watch somebody who's sleeping. At some point, about 1.5 hours after we go to sleep, you'll see their eyes moving rapidly. Even beneath the closed eyelids, you can make it out. That's when, some of the most restorative functions of the brain occur. The brain is active. But the non-REM sleep goes into N1, N2, and N3 sleep, and I'll come to this soon. There are various different kinds of sleep, and you can sleep. The brain doesn't have the same kind of activity throughout. So there's a lot of asynchrony between different parts of the brain when we go to sleep, and this is the result of recent research that is happening. How much sleep do we need? Okay, and it varies according to your age, and you can see a very young infant needs almost 14 to 17 hours of sleep, whereas as we grow older and older, it comes to somewhere between 6.5 and 9 hours of sleep. Sleeping less than 6.5 hours is unhealthy. Sleeping more than 9.5 hours is also unhealthy, possibly because it signals that there is something wrong with your health, and therefore you're sleeping longer. But a lot of people, young people these days, are sleeping less and less, and that will have an impact on your health in the future. So we know that we sleep less now than before. So in the early 20th century, it was thought that people documented 8 to 9 hours of sleep. But in 2002, it's dropped to 6 to 7 hours of sleep. And what is happening is we're going to bed later and later. And one of the factors that's contributing is there's a lot of ambient light all around. I'm sure you think of your bedroom, there's still a lot of light coming in from outside through the windows, and that is largely preventing us from sleeping. But equally important is the fact, I'm sure most of people sitting at the back will agree, you go to sleep with your mobile on. And the blue light of the mobile is particularly harmful to help you sleep. It keeps working on something called the chiasmatic nucleus, which is where sleep starts. So when you have that light, you cannot sleep. So again, a tip to students, do not go to bed with your laptop or your mobile on. You have to switch it off in order to get a good night's sleep. So how do we study sleep? Basically, we look at brain activity, the electrical activity of the brain, because that tells us what stage of sleep you're at. We look at the electromyogram, which tells us about muscle activity. And we look at the electrooculogram for eye movements, because as I just told you, rapid eye movement can be picked up through the electrooculogram. And we recognize that stages of sleep, because it's your brain that sleep, are reflected in EEG activity in the brain. Don't need to go into greater details of this, but I'd really love for dental professionals to take up more of sleep medicine, and I'll come back to this later. So most of your sleep is spent in N2 and N3 sleep, and very little in N1 sleep, because that's just when you're starting to fall asleep. You can come awake, go back into sleep, come awake. So that is just the introductory stage of sleep. REM sleep accounts for somewhere between 15 and 25% of total sleep time. And that's what you can see. As you go deeper into sleep, you go through the different stages. Each is a sleep cycle. The dark blue bars represent REM sleep. And as you go into the deeper and deeper into the night, the REM sleep phases get longer and longer. So this is a person who has a normal sleep hypnogram, the graphical recording of a person's sleep. But if that is fragmented, that can be associated with a lot of psychiatric issues. So these are the stages of sleep. In the beginning, the heartbeat and the breathing start to slow down. The muscles start to relax, and just a few minutes. And then as you go into N2 sleep, the heartbeat and breathing slow down even further. There are no eye movements at this stage. The body temperature starts to drop. And on the EEG, you'll start to see a very characteristic, what is called sleep spindle. And then you go into N3 sleep. And this is the deepest stage of sleep, where your brain is hardly working at all. Your muscles are very, very relaxed. Your heartbeat and breathing are at their slowest. And the brain, very slow activity is reflected in what is called delta activity, where you're seeing a frequency of the brain waves at between 0 and 4 hertz, 0 and 4 cycles per second. And this is where a lot of rest, tissue repair and regeneration occurs, and this is where your immune system strengthens. And if you lack N3 sleep, people fall ill frequently. They get colds and coughs and other infections. And then the very important stage of REM sleep, where most of the dreaming happens. You can also dream in N3 sleep, but most of your dreaming happens in N3. And if you wake up in a nightmare, it's often that you've just been in REM sleep. The eye movements start to become very rapid. The breathing and the heart rate suddenly increase. The limb muscles are almost not moving at all. And the brain activity is markedly increased, and you can see this between non-REM sleep and REM sleep. Red represents activity, and you can see a lot of the brain is very active in REM sleep, whereas there's hardly any activity in most of the brain in non-REM sleep. So I'm going to be focusing for the rest of my talk on sleep-related breathing disorders because that's my area of interest. And all these sleep disorders can be broadly classified, as you can see there. I'm not going to go into the others. So I'm going to be talking only about sleep-disordered breathing, often referred to as OSA, obstructive sleep apnea, though it's only one of the varieties of sleep-disordered breathing. Why should we know about it? Because it's a very common problem, as I'll show you later. If you have obstructive sleep apnea, it affects all systems of the body. And it's very important to pick it up early because early diagnosis, early treatment makes a difference. If you pick it up very late after damage to the heart or brain has occurred, you don't get such good results. And the treatment is not easy to give. It needs a lot of knowledge, but it also needs counseling skills. It's a very common problem worldwide. It's a description of how somewhere between 7.8% and 70% of the population seem to have sleep-related disorders. And you can see that as we grow older, sleep apnea becomes more and more common. And that's one of the measures that we use when a person, trying to find out what is the risk of having sleep apnea. As a person grows older, we use a cutoff of 50 in India, 55 in the West. The chances of having sleep apnea rise a lot. And you can also see that it's commoner among men than women. So I'm sure that if I did a questionnaire here, we'd find at least 5 to 10% of the population having sleep apnea. And that has been shown repeatedly. So this is a study from St. John's, and this was a study from North India. And you can see somewhere between 4.6 and 3.7% of the population, urban population and rural populations in Karnataka have sleep apnea. In North India, it was reportedly higher. And the truth is probably somewhere in between the two, that it's around 5 to 10% of the population have sleep apnea. Men have twice the risk of women. And why is it important? Because it affects all systems. And you can see this list of conditions, whether you're talking about hypertension, erectile dysfunction, end-stage renal disease, diabetes, fibromyalgia, waking up with a lot of aches and pains, heart disease, COPD. There is a lot of overlap between these two conditions, including congestive heart failure. And when you look at comorbidities, look at this drug-resistant hypertension. The person is taking at least 3 different medicines for BP, and still the BP is not controlled in full doses. 83% of the time it's due to underlying sleep apnea. And that's something the cardiologists are learning now, and people with drug-resistant hypertension or dysrhythmias are being referred to us for sleep studies. And you can see that all hypertensives, if you take, more than a third of them have sleep apnea. And this relationship is bidirectional. Obstructive sleep apnea causes obesity, causes diabetes or hypertension, but equally there's a bidirectional relationship there. And just few days ago, 15 days ago, we were at a similar function in Mysore, and I spoke about the microbiome. And somebody who spoke to us, an expert, thanks to Dr. Nagesh's inspiration, I spoke to Dr. Paul Salins, my boss, and said, sir, we need to start something on research on the microbiome. And he said, immediately, I will call somebody. He invited a Professor Shauche, who's doing research on this. And he was showing an almost similar diagram showing that the microbiome is affecting all these things. So I think we need one more area of research where we're trying to tie these two things together. But if you look at obstructive sleep apnea, the ones who have more severe sleep apnea have a greater incidence of non-fatal and fatal cardiovascular events, heart attacks, strokes, and so on, are much commoner if you have sleep apnea than if you don't have sleep apnea. So people who are just snorers don't tend to have much of a problem. People who have sleep apnea which is not treated have a much higher problem. And the same is true when you're looking at the occurrence of hypertension. The more the severity of the sleep apnea, the greater is the chance that a person will have hypertension and develop it. So the incidence of hypertension is directly proportional to the severity of sleep apnea. Similarly with cardiac arrhythmias, this is a long period of apnea. You can see there's no airflow, but at the same time the heart has stopped beating because there is no generation of QRS complexes. So the person is having an apnea, but at the same time the heart stops beating, and then suddenly the heart rate will speed up after the apnea is over, and that is often recognized by the cardiologist as a sick sinus syndrome, and they put in a pacemaker. Sudden cardiac death is very common at the night hours. If you heard of somebody who died in sleep, very often it's because they had sleep apnea. Whereas during the day, patients who do not have OSA are more likely to have sudden cardiac death. So there are other causes of sudden cardiac death, but nocturnal sudden cardiac death is often associated with sleep apnea. And similarly, the incidence of stroke, the higher the apnea-hypopnea index, I'll come to that, but it's a way of measuring the severity of the sleep apnea. The more severe the sleep apnea, the greater the chance that a person will have a stroke. And if you look at various cardiometabolic diseases, whether you're looking at them in terms of their occurrence of disease, or you're looking at their clinical presentation, or you're looking at demographics, or their biochemical assays, everything is much higher in persons who have sleep apnea, and that is reflected in the bad outcomes that they have. And an area that I'm particularly interested in, pulmonary hypertension, is also more common in people who have sleep apnea. The risk of diabetes, as you can see on this forest plot, is almost significantly higher in people who have sleep apnea than in those who don't have sleep apnea. And you can see that it rises to about 1.5 times that of a person who does not have sleep apnea. And most importantly, the more severe the sleep apnea, the higher the chances of dying. The probability of survival falls sharply when you have severe sleep apnea as compared to somebody who has no sleep apnea, an apnea-hypopnea index of less than 5. So, recognizing that it is an extremely important thing to pick up, diagnose sleep apnea, how do you suspect obstructive sleep apnea? So this is the classic silhouette of somebody with sleep apnea, somebody who has retrognathia and a large stomach, because those are the typical features that you see. And very often as a person is walking to my clinic, I can recognize that they have sleep apnea. And you have to ask a lot of questions, you have to put them at their ease. So the counseling and everything takes still about 20 minutes, but the diagnosis is made almost instantly as they walk in. And I can walk through our ward, or especially the intensive care unit, look at patients on either side and say sleep apnea, sleep apnea, sleep apnea, because it is highly associated with complications that land a person up in the intensive care unit. As I already mentioned, as age advances, the chances of having sleep apnea are higher and higher. But this is where dental surgeons come in. And all of you open the patient's mouth in order to practice your specialty. And these are the typical features. So when you ask a person to open their mouth without phonating, so they don't say ah, just ask them to open the mouth, and you can see this is the class 1 Malampatti, the class 2 Malampatti. So the class 1 Malampatti, I'm going to spend a little time on this so students can see this and practice it. If you can see the whole uvula, you can see all the tonsils and the pillars very clearly. That's a class 1 Malampatti. And we should be proud because it's an Indian man, a person from Andhra who first described this, obviously in the United States. Class 2 is when you cannot see the tip of the uvula, but you can see the base of the uvula. A class 3 is when you cannot even see the base of the uvula, you can only see the soft palate. And a class 4 is you can see only the hard palate and not the soft palate. The higher the Malampatti score, the more difficult it is to intubate the patient, which is why the score was described as an assessment of how easy it is to intubate a patient. But at the same time, it's a very good marker for obstructive sleep apnea. And class 3 and 4, I'm already aware that this person may have sleep apnea, even if he does not look like the Hitchcockian figure you saw with the retrognathia and the paunch. The other is to look for scalloping of the tongue. So if you see these ridges at the side of the tongue, that again is a very strong indicator of obstructive sleep apnea. And this happens because of two reasons. One is the tongue is disproportionately large for the oral cavity. And the second is when a person sleeps, the tongue keeps thrusting because the airway is blocked. The tongue keeps thrusting against the teeth and leaves these marks over a period of time. So when you say, ask the person to open their mouth, ask them not to phonate, don't say ah, look at the Malampatti score, look at the scalloping. And if you find these two, think strongly of the possibility of sleep apnea. So the next thing you can do is apply what is called the stop bank score. The stop bank score is just an acronym. Each of those stands for a particular word. So S stands for snoring. Does the person snore? Does he snore louder than usual? So very often wives have banished their husbands to a different room. It's called a bedroom divorce. It's because they cannot sleep. It's, they're snoring so loudly. And it's usually the man who's snoring loudly because, as I told you earlier, the men are the ones who are more likely to have sleep apnea. Do they often feel very tired? So the wife said the man was snoring throughout the night. I was shattered. I couldn't, work in the morning. But the husband says, I'm still feeling very tired. I wish I could sleep for another 6 hours. The wife will often tell me that the person has stopped breathing. And one woman told me, I thought he died. I was going to shake him awake and try and bring him back to life, and he started breathing again. And that's a very typical thing. But this happens when they're in REM sleep, so 1.5 to 2 hours after the person sleeps. Is the person on treatment for high blood pressure? So that's the P of stop bang. Are they obese? Do they have a body mass index more than 30? Is their age more than 50? The neck circumference more than 40? A simple question to ask is, what collar size do you take, even if you don't have a measuring tape with you? And is the person male? Okay, so if you look at the front rows of this, you will find that there are many 50-year-old males. They're already scoring 2. And why is it important? Because if you have a score of between 3 and 4, you have an intermediate risk of having sleep apnea. And if you have a score more than 4, you have a very high chance of having sleep apnea. So that's the second step. After the physical examination, we specifically ask about the stop bang score. So I'd suggest everybody here does it, because even the young people at the back, there's something like a 2 to 5% chance that you may have sleep apnea. It will interfere with your sleep, it will interfere with your academic performance, and it will have an impact on your future health. So what we do next is do a polysomnography. We measure the sleep. That's what polysomnography means, somnography. And the poly refers to the fact that we look at various different parameters. So all of those parameters are what we look at using various electrodes, which record brain activity, eye activity, muscle activity. We check the oxygen. We check is the air coming in and out of the nose and mouth. We see if the chest is expanding and the abdomen is expanding with each breath. We take an ECG at the same time. And as I said, we also look at the muscle activity of the legs, apart from looking at the muscle activity of the chin. And that's what it used to look like. So we used to attach all these leads to them and then say, now sleep as you would at home. And you'll be surprised actually that people with sleep apnea sleep beautifully through most of the night, at least 80% of the night. But these days we are slightly better, and that's the entire recording that we need to do. So it's not surprising that we get good recordings these days. And that's the kind of recording we get. That's called a epoch that we are seeing. And you can see all the different electronic parameters or electrical parameters that we are recording. But don't worry, as a sleep specialist, there are technicians who do this job, though you should be aware of it. Notice that it also includes a video which is recording their activity through the night. And the person who's doing the sleep study, the technician, is in the next room, able to keep an eye on the patient having the sleep study. So what are we looking for? We're looking for apneas. So the person is asleep, as we can make out from the EEG. There's airflow in the beginning, and then the airflow stops. But the person's respiratory effort continues. And it used to be done with the esophageal pressure reading. But now we just use bands over the chest and abdomen to see if the chest is moving, abdomen is moving. If the chest and abdomen are moving but there's no airflow, it means there is an obstruction somewhere in the airway. And that's typically in the upper part of the airway behind the tongue. So that was an obstructive apnea. But sometimes in sleep, there is no airflow, but there's also no effort. So that we call a central sleep apnea, where there's no effort to breathe also. The apnea starts in the center. And finally, you have a person who initially makes no effort, but then he starts to make an effort and still there is no airflow. So this is called a mixed apnea. It starts as a central apnea and becomes an obstructive apnea. And why is this important? Because we look at the apneas, which is a complete cessation of breathing, or at least a 90% drop in the flow. And we look at hypopneas, where you get a 30% reduction in flow and a 3 to 4% reduction in the oxygen level. And we add up the apneas and the hypopneas, we add up the apneas and hypopneas, and we get something called the apnea-hypopnea index that I mentioned earlier. Anything more than 5 tells you the test is positive, the person has sleep apnea. Between 5 and 15, it's mild. Between 15 and 30, it's moderate. And more than 30 is severe sleep apnea. And that's the kind of sleep study that we get. I'm not going to waste too much of time, but we look at the stages of sleep. We took how long it took to get into each stage. We look at how efficient the sleep was. And this is like a summary of the entire sleep profile. And then we give them a final report. This person had an apnea-hypopnea index of 28.3, which suggests that almost once in 2 minutes he was having an obstruction, complete or partial, that was causing his oxygen to drop and the carbon dioxide to go up and causing a lot of other physiological changes. And we look at specifically various different parameters. I'm not going to go into these, but that's what a full sleep report looks like. And this is like a nice graphic summary. That's the hypnogram, which you can't see it very clearly, but you can see this person had just one episode of REM sleep. The oxygen level was falling at times when there was respiratory obstruction. So each of these lines is a respiratory obstruction. The height of the line is how long it lasted. And you can see whenever you had a clustering of these apneas and hypopneas, the oxygen level is falling a lot. Similarly there, wide variations in the oxygen level. And at the same time, you're having a huge variation in the pulse rate. So your oxygen is going down, your heart rate is shooting up, and that's a recipe for disaster because you're straining your heart while not giving it enough oxygen. So we put them all together. If the initial stage of the study you saw 28.3, bordering on severe sleep apnea, you put a person on a machine called the CPAP machine, which I'll come to, and now suddenly the apnea-hypopnea index has dropped from 28 to 4. That means this person has moderate sleep apnea, which gets much better on CPAP treatment. And that's the same thing you saw. You saw the huge variations in the oxygen level and the obstructions, now much less on CPAP and a much more stable pulse rate, though it's not completely stabilized yet. And that can happen because a person is dreaming. And in REM sleep, you can get a lot of tachycardia. So your history and examination suggest obstructive sleep apnea, including a sleep study. We do a polysomnography. If the respiratory disturbance index or the apnea-hypopnea index is between 5 and 15, the test is positive. If it's more than 15, there's no question. You have to do some general measures, which I'll come to. But if the person has an apnea-hypopnea index between 5 and 15, that means it's mild disease still, and the person is symptomatic or has other cardiovascular risk factors, such patients we will decide to treat. So if they don't have these risk factors, we just follow them up. If they have risk factors, we first look for an anatomic obstruction, and that's again where ENT and dental surgeons come into play, the maxillofacial surgeons especially. If there is an anatomic obstruction, you try and correct it. If there is no anatomic obstruction, we use a CPAP machine. The person gets better, wonderful. If not, we follow up and plan some other treatment. So what are the treatments we can use? We advise them to lose weight. We advise them to, if they have apneas only when they are lying flat on the back, we advise them to sleep on the side, which is not easy. Various drugs have been tried, nothing really works. Oral appliances are very popular among the dental community, and something called myofunctional tongue stimulation, which I'll come back to later. And what does CPAP do? Basically, that's the very narrow airway that you're seeing, that tiny little black rectangle. When you put CPAP, it expands hugely, and you can see that the airway has opened up. And that's what CPAP does. It's continuous positive airway pressure, which blows a steady stream of air, just enough to keep the airway open. And that's the interface. Those are the various different kinds of masks that you use. And believe me, it seems uncomfortable, but I have sleep apnea. Okay, and I use it every night, and if I don't use it, then I'm extremely uncomfortable the night falling asleep during its classes. And I used to blame them and say, these chaps are very boring, they can't keep me awake. But in reality, it was my sleep apnea that was making me fall asleep during their classes. But does CPAP work? Yes, it does. You can see it leads to weight loss as compared to those with control. It has huge benefits in terms of the cardiovascular metabolic parameters that I told you about. Diabetes, definitely within just 4 hours of glucose use, the glucose comes down. And if you use it less than 4 hours also, you get a benefit, but not so much of a benefit. And if you look at what is called the insulin sensitivity, it improves within about 3 months of starting to use CPAP. So it helps with diabetes, it helps with heart disease. And the incidence, the new occurrence of sleep apnea is much less in people who have no sleep apnea as compared to those who have sleep apnea. But you need to start CPAP early, and that's where, again, I think dental surgeons come in. If you make an early diagnosis, because you can see the oropharyngeal space when you're examining a patient, if you start CPAP early, you will get benefits. But this was a study which showed that after a cardiovascular event has occurred, if you started CPAP, they didn't get benefits. So early diagnosis, early treatment is extremely important. The problem is people don't use CPAP. Okay, if you have mild or moderate OSA, the chances that you will continue to use it in 2 to 3 years is very low. And that is a tragedy because, as I just showed you, it reduces mortality rates quite significantly. So various different kinds of devices apart from CPAP have come up, which have made it easier to breathe, but not everybody needs this. But that's again where the maxillofacial surgeon and other dental surgeons come in, because people do use mandibular advancement devices. Are they as effective as CPAP? No, they are not. But they are more acceptable to patients. And when you're talking about efficacy, you have to be sure that the patient is able to use something. So for example, if you look at CPAP, very efficient, more than 80% efficacy. But compliance with treatment is only about 60%. On the other hand, with a mandibular advancement device, it's only about 50 to 60% effective. When a person is able to use it for 80% of the time, you're going to get more benefits in the long run. So I would strongly urge everybody to try CPAP, but if he's absolutely sure I'm not going to use this, then I would advise. The other is where the maxillofacial surgeon comes in, and this is a surgery that was performed on one of my patients by Dr. Paul Salins and team. So what they do is they do a genial muscle capture and advancement. You can see the mandible is, there's an osteotomy in the mandible, it's pulled forward, and you can see the end result, that's the plate. And you know that's where the genioglossus gets attached. When the genioglossus is pulled forward, the tongue is pulled forward, and the space behind, the retropharyngeal space improves. You also do a uvulopalatal flap. You roughen the surface, anterior surface of the uvula, and stitch it to the palate, so that increases space available also. And you can see that that airway, which is very narrow, has improved in the most important area. This is where the in a multi-level surgery, the posterior part of the tongue is also shaved down to increase the space. So you've shaved it down, and the space therefore increases hugely, and you can see the entire silhouette of the patient has changed. She who had a retrognathia had it pulled forward. I don't know how much her sleep improved, but certainly her cough, very, very troublesome cough. I could hear her for 2 hours before she actually reached my clinic, because she'd be coughing in the waiting area outside. And that almost vanished after they performed the surgery. And another famous politician, you hardly hear him coughing now, also underwent the surgery and treatment for asthma with us. Okay, so it works beautifully, but it is major surgery, as you can see. So the other thing we do is we advise myofunctional therapy exercises, various exercises of the tongue and pharynx, and they seem to have some benefit, especially in mild sleep apnea. We do not try these in severe sleep apnea, but they're a very useful accompaniment to patients who are receiving CPAP also. I'm not going to go into these are available on the net, and I would strongly suggest every person whom I put on treatment to do these. And of course, something which is very popular in India, acceptable culturally to us, is yoga. So, and I always advise my patients to do these 3 parts of yoga, Nadi Shodhana or Anulom Vilom, Brahmari, because that strengthens the throat muscles, and what is called Ujjayi breathing, where you breathe in through the nose, but it seems to touch only the throat, and therefore that also strengthens the throat muscles. So these 3 parts of yoga, along with everything else you can do, the tongue exercises, seem to have significant benefits. We were going to do a study on this. Unfortunately, the person who was supposed to collaborate with me got another job, went away. So this is not evidence-based, but people who play wind instruments seem to have a significant improvement in their apnea-hypopnea index when they are playing, when they learn how to play, rather than people who don't use a wind instrument. So musicians who play a stringed instrument have worse outcomes, higher AHI, than people who play a wind instrument. So that's the efficacy of myofunctional therapy. You can see very good improvements in patients who actually do myofunctional therapy. This was a systematic analysis that happened, a meta-analysis that happened. So I'll stop at this point, leave you with a few key messages. Good quality sleep of adequate duration is essential for the maintenance of good health. That's the first important message, especially for the young people. Obstructive sleep apnea is a very common, unfortunately often diagnosed disorder. When you suspect it on the basis of symptoms, clinical features, risk factors, you can use a screening tool like a stop bank score and identify who should have the more detailed tests. And the diagnosis can be confirmed or ruled out with polysomnography. If it's untreated, obstructive sleep apnea has severe health consequences. On the other hand, treatment can reduce these consequences, but you need to start treatment early. CPAP is the ideal treatment, but for patients who are unwilling to undergo CPAP, surgical or mandibular advancement devices work very well. I'll stop at this point. Thank you all for your very patient hearing.
Thank you, sir, for this very request our principal, Dr. B. Sir, to give away the certificate to the speaker as well as the
the moderator has been doing a terrific job. Thank you so much. If there are any questions, I'd be glad to answer. Any questions, doubts, disagreements?
Sir, does this sleep position influences the apnea? Sleep
So one of the things I didn't show you is something called the position at which obstructive sleep apneas occur. And there is a subsection called positional sleep apnea, where a person gets it only on their side. The apneas seem to almost completely vanish. But this is a very small percentage. And such patients, you can advise positional therapy. The old treatment used to be, they used to suggest stitching a tennis ball into the back of your nightshirt. So when you sleep on your back, it's very uncomfortable, you automatically turn to your side. That has not been shown to work in most sleep apnea. It works mainly in positional sleep apnea. So position is important, but it's not completely important. I can vouch for the fact that many people snore loudly on their sides and have sleep apnea. Yes, sir. So, 2 or 3 things. The first is, of course, open your mouth, put your tongue out, look in the mirror and see if you have one of those 2 signs that I mentioned. The second is look at your silhouette. Take a picture from the side and see if you have a retrognathia, mild or severe. The third is the symptoms that I spoke about, the stop bank questionnaire. Excessive snoring, loud snoring. Everybody I ask says, no, I don't snore. And I can see the wife in the background nodding furiously saying, yes, he snores very loudly. So you have to ask the spouse, not the patient himself. Then check if they have blood pressure which is becoming difficult to control. Is their diabetes, out of control? A very important thing is the person says, I'm dieting, I'm exercising, unable to lose weight. But 10% of persons with sleep apnea are of normal weight. You can see this, despite this, I'm not terribly overweight. I'm in the correct weight band, and yet I had sleep apnea. Okay, so these are some of the features we look at. The metabolic parameters, of course, what are the risk conditions that we mentioned, do the stop bank questionnaire. But I think the easiest thing is to open the mouth and take a look. It doesn't rule out the presence of sleep apnea, but the presence of a high Mallampati score or tongue scalloping immediately alerts you to the possibility of sleep apnea. So with all these things, then you have a strong suspicion. My recommendation is everybody should take the stop bank score. It's a very simple score. Everybody should know their blood pressure. Everybody should know their waist, the neck circumference. They should know their BMI. These are parts of normal health. When I sometimes ask people, how much is your bank balance? What is the pressure in your car or scooter tires? And they have it like that. Ask them what is your BP, what is your cholesterol, and they have no clue as to what those very, very important numbers are. So look at the metabolic parameters, including blood pressure. And if you have those out of control, think, could I have sleep apnea, and consider it. The other, as I said, is falling asleep. I didn't show you one important slide, which is deaths occur due to a variety of conditions in sleep apnea. 10% of deaths in the United States are due to sleep apnea. And these are often fatal road accidents because a person falls asleep while driving. And in the United States, they drive at high speeds. In India, we drive at high speeds with more crowded roads. And when they fall asleep, the case fatality rate is supposed to be higher than drunken drivers, because a drunken driver at the last minute knows enough to swerve. A person who's asleep just crashes straight into the other vehicle. I've had at least 3 patients fortunately survived. One person almost drove off the Charmadi Ghat when he was driving. He's from South Canara. Driving there, drove off the road. Fortunately, his car crashed into a tree. So he lived to tell me about it. Two others had a road accident. One of them was going to go over the bridge and almost fell into the river. Fortunately, it hit the side of the bridge, the pillar of the bridge, and stopped there. So road traffic accidents are well known. A lot of bus drivers, in fact, one of my former students and colleagues insists we should do a sleep study for every single long distance driver. So that is, I think, extremely important, but that's something when you examine a person, you know, you can make out immediately. So those are some of the things that we always look for. Yes, ma'am. On oral cancer. Sorry? Oral health. Very, very good question. So a lot of people with sleep apnea have dry mouths, open mouths, because they breathe through the mouth. They cannot breathe through the nose. The nose is partly obstructed very often. They have bad DNS, so they tend to breathe through the mouth. And I think you know better than me that absence of saliva. And remember that during sleep, for all of us, saliva secretion comes down. And that's because if not, we'd be drooling all the night during sleep. So the amount of volume of saliva comes down, but when you're breathing through the mouth, it dries up, and that, of course, leads to significant declines in oral health. Apart from that, of course, you tend to get changes in the oral microbiome. You get, you know, a lot of infection because the filtration activity of the mouth is lost. You keep your mouth closed, so that is lost. So there's a lot of ambient pollutants which get dissolved in the oral cavity. So that can also cause disturbances to oral health. But that exactly is why I want a greater interest in sleep medicine in this population, especially in you know, the maxillofacial surgeons, because I think that's becoming more and more important. Sir. When you should consider? So, age group, everybody. Everybody. Sleep apnea is very unusual in children because of this, but if you find a child with retrognathia, you find a child with large tonsils, you find a child with nasal block, especially due to allergic rhinitis, for example, and some of the clues lie outside the mouth. So, you know, you find a child who walks into your clinic doing that because they have allergic rhinitis, they're dripping from the nose. They have what is called an allergic crease. So on the bridge of the nose, you find a horizontal crease because they're pushing up the nostril, and they almost inevitably will have allergic conjunctivitis. They're rubbing their eyes, so they get blackish circles around the eyes. We call them allergic shiners. So when a child comes with all those, suspect the possibility that they have upper airway allergy, which predisposes to sleep apnea. Then you can ask questions. One of my good friends, his child had very severe sleep apnea at age 2.5 or 3. And some of the clues are bad performance in school, irritability, not just falling asleep, but also hyperactivity. So one of the causes of ADHD, or one of the features of obstructive sleep apnea, is a child who behaves like they have attention deficit hyperactivity disorder. So in a child, you look for those because they don't have the classic obesity, sugar, BP, and things like that. So great question, but that's how it's picked up by the pediatricians. Somebody had a question there? Yes, please. You may have to shout a little.
Good afternoon, sir. Sir, my question is, I want to know about the people who go to work at night time and sleep from morning till afternoon. Is their sleep is good enough like how we sleep in the night time?
Excellent question again. You know, that's a modern problem, shift work. So especially when you're talking about the BPOs, you know, they have to correspond to Western timing. So they sleep during the day. So it is slightly unnatural, but what we try and do is make it as natural as possible. So they can't give up their jobs. So what you advise them to do is completely darken the bedroom. There should be no ambient light at all. 2, they must follow the same kind of 24-hour cycle, which means when they return from work, they have their dinner, even if it is the morning, you have your night dinner at that time. You go to sleep in complete darkness. When you wake up, you have your breakfast. Just before you go to work, you have your lunch and then you go to work. Or you go to have your breakfast, go to work and carry your lunch there. So you're essentially replicating the same cycle that you would if you had the normal 24-hour cycle. So that's what we're trying to do, because there's no other way you can do it. They have to work and you have to try and replicate the normal cycle. Most people make the mistake of trying to work, then they come, they want to meet friends, they want to go shopping, so their whole schedule gets disrupted, and that has very, very bad effects on physical and mental health. So great question again. Thank you. Yes, sir. So I think the main problem with sleep apnea, again I didn't show that, is sleep apnea leads to obesity, because during in patients with obstructive sleep apnea, like in diabetes you have insulin resistance, these people have leptin resistance. Leptin is a hormone which, as the name tells you, keeps you thin. It reduces the appetite, it makes you eat less, but it also helps to burn calories. So the presence of it, the basal metabolic rate goes up and you burn a lot of calories, and it produces a lot of carbon dioxide which gets blown off. When you have sleep apnea, there's leptin resistance. So the exact opposite happens. They are able to put on a lot of weight, and they tend to have no suppression of the appetite. So they eat more, they exercise less, they burn less calories, so they put on weight. The diet, therefore, you need to advise is a weight-reducing diet, okay, which is low in calories, and that's one of the essential parts of the initial treatment for those with milder sleep apnea. So between 5 and 15, they don't have any significant risk factors or symptoms. Then these are the things we try. We advise them to lose weight through diet, exercise, and so on. But there is no specific diet which reduces the risk of obstructive sleep apnea. Absolutely. As I mentioned, for children, even for adults, local factors can be exacerbated by environmental conditions. So you are in a environment where there is a lot of allergy, there's a lot of pollution, you have nasal upper airway swelling, then that can definitely aggravate sleep apnea for two reasons. One is there is obstruction, but the other interesting thing that happens, it's postulated, is that when you have a rather blocked nose, air is going in, you're breathing in through the nose. What is happening is, it's going through a very narrow passage and suddenly expands. So that causes a loss of pressure, or drop in pressure, the Bernoulli effect. And therefore the airway is pulled in at such times. So an obstruction gets aggravated when a person has sleep, allergies, which can then show up as sleep apnea. So yes, environmental conditions play a role, but they usually show up first as allergies or upper airway irritation. The other thing that possibly plays a role is gastroesophageal reflux. That's again something the ENT surgeons are very good at picking up, because they can see what they call laryngopharyngeal reflux with evidence of inflammation in the throat. By the way, one of the other things you should look at when you look at patients like this is look at what is called cobblestoning of the posterior pharynx. So when you see that when a person opens the mouth, that again is a strong indicator of upper air allergy, and little bulb should go off in your brain saying, should I also ask about sleep apnea? Okay, so a lot of the findings, this is the disease of the upper airway, fall exactly into the domain of the ENT and dental surgeons.
It was an excellent presentation. It was the right topic. Last time also, microbiome, that was a great topic. Interesting dental surgeons. And Dr. Nagesh was spontaneous to initiate research. And this sleep apnea, dentists at the privileged position, please, because all age group, especially youngsters, visit us. And if we get into this, that will be a big service to the humanity. I think you have created a lot of interest. You can see the questions will go on, but time will also go on. That's why I want one small clarification. See, gets off frequently. So it is limiting the question. See, you have shown MRI. an MRI, but we take frequently CBCTs. That also shows here. We come across, we can measure CBCT. Whether it is going to be some useful parameter to refer the patients. Because normally what I notice is 8 to 12 should be normal airway. This one, we come across between 3 to 5. So what is your take on this?
So again, an excellent question. I don't have such good questions when I address a medical crowd. So I'm very, very, very happy to be talking to all of you. So a CT is very useful. In fact, in our institution now we have a cone beam CT where a person it can be done sitting or standing. But we also do both CT and MRI, dynamic MRI, where we sedate the person to simulate sleep, and then we do the dynamic MRI. So you can see the difference between when a person is awake and when a person is asleep. At the same time, our ENT surgeons do what is called drug-induced sleep endoscopy, or DISE. So we look at the upper airway, we sedate them with a sedative, calling in the anesthetist. When the person is deeply sedated, you can mimic the same conditions as happens during sleep apnea. But yes, so just a simple CT of the upper airway will definitely give you a clue. And if you see a very narrow upper airway, that itself should alert you that this person may have sleep apnea. But people who have a normal upper airway but have strong features to suggest sleep apnea, it's worth doing a dynamic MRI or a dynamic CT and a drug-induced sleep endoscopy. And just to take that further, because this is an interesting area, CPAP sometimes doesn't work in some people because the upper airway is collapsing inwards. And when you put pressure from above, the collapse even worsens. And that you can pick up when you do a sleep endoscopy. And those patients, there's no point in doing, insisting they use CPAP, because it's actually worsening the situation. And that's again where the maxillofacial surgeon and the ENT surgeon jointly operate and produce good improvements.
So thank you so much for a great presentation. We all enjoyed
Thank you so much.
Not only enriched. Thank you so much.
Thank you, sir. Now I request Dr. Praveen B. Kudwa, sir, to give away the certificate for the speaker.
I request the alumni, I think for the first batch, to join me when giving the certificate. I'm sure sir will be very proud that they're all here.
Now I request Dr. A.V. Ramesh, sir, and Dr. Vijendra, sir, to give away the certificates for the moderators, Dr. Kodan and Dr. C.V. Mohan, sir. Now I would like to call upon Dr. Padmaja ma'am, HOD Department of Prosthodontics and Crown and Bridge, to give a brief introduction of Dr. Vinay and Dr. Sandeep, who will be conducting a workshop on ECG. Ma'am, please.
Thank you, Dr. Anusha. It gives me immense pleasure to introduce our two speakers for today's workshop on ECG, Dr. Vinay K.S. and Dr. Sandeep. Dr. Vinay K.S. pursued his MBBS from JSS Medical College in March 2011 and MD General Medicine in Mysore Medical College in April 2017. Sir is assistant professor. He did assistant professor in Department of General Medicine, SSMC, and now he is pursuing as associate professor. Sir has various scientific paper presentations and publications in national and international journals. The various courses pursued by Sir is basic courses in medical education and health research fundamentals, diploma in diabetes management by Royal College of Physicians and grand clinical practice. Sir is a resource person in workshops and ECGs in National Conference for medical students in 2022, and resource person for the interns training program in Siddhartha Medical College, resource person in CME on COVID-19 pandemic conducted in SSMC, and worked in COVID task force team in Tumkur, and art nodal officer in SSMC. And Sir is a co-investigator in clinical trial of Zydus COVID vaccine. Welcome, sir. Dr. Sandeep, sir, he pursued his MBBS in the from Sri Devaraja's Medical College, Kolar, and is MD in Sardar Patel Medical College, Rajasthan. Sir is presently Associate Professor in Department of Medicine, Siddhartha SSMC. Sir was employed by Mahidol Oxford Medical Research Center as a research assistant in 2011 at SP Medical College, Rajasthan. And Sir is an international associate researcher in American College of Cardiology. He has completed his course on diploma in clinical endocrinology and diabetes in Royal College of Physicians, and completed courses on unraveling benefits of genetic 2 basal insulin at initiation in type 2 diabetes patients. We welcome both Dr. Vinay and Dr. Sandeep for today's workshop on ECG. Thank you, sir.
Good afternoon all. I'm Dr. Sandeep from Department of General Medicine. I'm going to discuss about ECG. So first of all, basics of ECG. Okay. So ECG, it's a simple and basic investigation we do, and it is essential for almost all the cardiac diseases. And it's a huge topic, and I try to keep it as simple as possible. So William Einthoven is a person who first recorded ECG, and he was awarded Nobel Prize in 1924 for the same. So all the ECG credit goes to this great human. So what is ECG? It's an electrocardiogram. It's the recording of the electrical activity of the heart by placing the electrodes on the body. So these electrodes, we call it as leads. So there are 12 standard leads. There are limb leads, 6 chest leads. So among limb leads, there are bipolar leads and augmented leads. So bipolar are 1, 2 and 3. Augmented leads are AVL, AVR and AVF. There are 6 chest leads from V1 to V6. So this is how we record ECG. You can see the leads over the anterior wall of the chest. We call them as chest leads, and the limbs which are attached to limbs, they are limb leads. So here one important thing is, so most of the time paramedics will record the ECG. Whenever you place ECG, there will be labeling on the ECG leads or electrodes. So they should place the electrodes properly. If there is any misplacement, there will be technical errors. So that we can make out while recording, interpreting ECG, that I will tell you later. So I told about this, an electrical activity we measure through the ECG. So what is that electrical activity? It's an normal impulse which has conduction through the heart. That is, the impulse generates in the SA node followed by AV node through the internodal pathways, then it crosses the AV node and reaches the bundle of his, then the right and left bundle branches, and then it reaches the Purkinje fibers. So this electrical activity we record in the ECG and interpret. So this is all of you I think got the ECG templates. So can you see the ECG strip? So among that we have selected one large box. So in this ECG leads we have y-axis, vertical axis, y-axis, and horizontal axis, x-axis. So here x-axis we measure one large box of x-axis, we record it as 0.2 seconds. So that means each large box contains 5 small boxes in horizontal and vertical direction. So in horizontal direction, that is x-axis, each large box represents 0.2 seconds. That means each small box is 0.04 second. So in vertical axis, one large box measures 0.5 millivolt. So one small box represents 0.1 millivolts. So ECG with which we record is 25 mm per second. So this is the normal ECG strip. So we should know these values. That is very most important. And among the previous ECG, we have selected one ECG. I think you can't see this clarity of waves in all the ECGs you will get. So this is just for explanation. We have selected one ECG wave and we try to explain this. So here there are waves. Initial first wave is the P wave, which is followed by Q, R and S, 3 waves. Together we call it as QRS complex. Then there is a T wave, which is followed by sometimes U wave. So usually along with these waves there are 3 more important factors. One is PR interval, QT interval and ST segment. PR interval, that is from the beginning of P wave to the beginning of Q waves. That distance we call it as PR interval, and beginning of Q wave to the end of T wave, that is QT interval, and end of S wave till the beginning of T wave, that is segment we call it as ST segment. So here one how to remember is segments doesn't contain any waves in between, but intervals there are some waves in between. So along with waves, PR interval, ST segment and QT interval, they are present in the ECG. You need to analyze those also. So how does this waves represent the electrical activity of the heart? One is P wave, that is initial wave, which represents the atrial depolarization. Then QRS complex, all the 3 waves, 2 negative waves, one Q and S and one positive wave, R wave, this represents the ventricular depolarization. And the T wave, which represents the ventricular repolarization. And one more factor I told, PR interval, that is beginning of the P wave to the beginning of Q wave. That interval, it represents the atrial depolarization plus delay in the AV junction. I told the node impulse generates in the SA node, through the nodal pathways it reaches the AV node. This PR interval represents the duration which required for the impulses to cross over the AV node and reach the ventricles. That delay is represented by PR interval. This delay allows the contraction of the atria before the ventricles. That is the reason atria contracts before and ventricles later. So this is about basics of waves, intervals and the measurements we use before interpretation. Now how to interpret ECG? There is an order. In this order, if you go and interpret any ECG, you will not miss any findings. First one is we calculate the heart rate. So how to check the heart rate in ECG? I think you can see the ECG strip. So here all the waves I think you can make out in this ECG. Okay, P wave followed by QRS complex, then followed by T wave. So here how to calculate heart rate? You should see the number of big boxes in the between 2 R waves. So here almost 3 big boxes are there between RR interval. That is between 2 R waves there are 3 big boxes. So if you calculate 300 divided by RR interval, that is number of big boxes, that will give an exact what is the heart rate of the patient. So here 300 divided by RR interval, here RR interval is 3 big boxes. So that gives heart rate is around 100 beats per minute in this patient. This is applies when the ECG rhythm is normal. Okay. So if the ECG rhythm is irregular, there is one more thing. You need to count you should record a ECG for a period of 6 seconds. 6 seconds means, I told one large box represents 0.2 seconds. So you should record ECG for almost 6 seconds. Then you should calculate the number of R waves in that 6 seconds into 10. That will give you the exact heart rate of the patient. Either you can record for 6 seconds and multiply by 10, or you can record by 10 seconds and multiply by 6. That will give you the heart rate of the patient when the rhythm is irregular. If it is rhythm is regular, easily you can calculate 300 divided by RR interval. So I told about rhythm. So what is rhythm? Look at the RR distances. The distance between all the R waves, that is, it should be same in all the leads. That is 3, 3, 3. So if the rhythm is between two RR intervals, if the number of large boxes or small boxes, whatever, it is same, then we call it as rhythm is regular. If there is irregularity, it is not equal. If this interval is 3, this interval is 4, there is a variation is there, then we call it as rhythm is irregular. So in irregularity there are types. Occasionally irregular, it could be because of ectopics. That means all the impulses generated from the SA node. If the other than SA node, if anywhere impulse generates in the either atria, AV node or fibers, then there will be extra pulsation. So that activity is recorded and that will be regular, occasionally irregular. If it is regularly irregular, that means every 3 intervals will be normal, every 4th will be irregular, every 2nd will be regular, or every 3rd will be regular. If such kind of regularly irregularity, that I can see in heart blocks. If any heart blocks, 2:1, 3:1 we call it. In case of heart blocks, there will be regularly irregular. Irregularly irregular. So you cannot compare the intervals between any RR intervals. That is irregularly irregular. That we see in conditions like atrial fibrillation. So first you should assess whether it is regular. If it is regular, it's fine. If it is irregular, you should also notice whether it is occasionally irregular, regularly irregular, or irregularly irregular. Those 3 things you need to note down if it is regular. Then assessment of P waves. After rate rhythm, you should assess the P waves. Usually there are 12 leads, but ECG P waves we assess in lead 2 and V1. First thing, you should note down whether the P waves are there in all the leads. Second thing, all the P waves morphology looks same. Then is all the P waves followed by QRS complex. Then you should see the height and width of the P waves. Normally, height of the P wave will be less than 2.5 small boxes, whereas width will be less than 2.5 small boxes in case of width. That is normal P wave. So P wave should be there in all leads. P wave should be, morphology should be same in all leads. P wave should be followed by QRS complex, and you should note down height and width of the P wave. What are the abnormalities? With the P waves, height is more than 2.5. The height is more than 2.5, we call it as P pulmonale. That indicates right atrial enlargement. The P mitral width is more than 2.5, that indicates left atrial enlargement. If the P waves are absent, that we can see in atrial fibrillation, ventricular tachycardia. So if the P waves are of different shape, that indicate probably because of premature atrial complexes, that is ectopics. You can see different shape. So here we can make out this is a normal P wave, height and width are less than 2.5 small boxes, but here you see the P pulmonale. Here height is more than 2.5 mm, that indicates right atrial enlargement. Here width is more than 2.5, that indicates P mitral, that is left atrial enlargement. So after P wave, we should assess the PR interval, that is beginning of P wave to the beginning of Q wave. This interval we call it as P wave interval, that indicates the transmission of impulses through the AV node. So here normal duration is 0.1 to 0.2 seconds, that is 3 to 5 small boxes. If that distance is between 3 to 5 small boxes, we call it as normal PR interval. If it is shorter, it can be seen in conditions like WPWS syndrome. If it is long PR interval in AV blocks, we can see the large PR interval. So after T wave PR interval, now we go to QRS complex. Here Q waves are the Q and S are the negative waves, R is positive wave, but together we assess it as QRS complex. Usually we assess QRS complex in chest leads, that is V1 to V6. Here you should see the first thing is duration of the QRS complex. You should see altogether these 3 waves, the duration should be less than 0.12, that is less than 3 small boxes. Okay. Second thing is R wave progression and S wave progression. In V1 you see S waves are prominent, whereas in V6 R waves are predominant. So there will be R wave progression. So R waves will be, amplitude of the R waves will be keep on rising from V1 to V6. That is normal thing. Second thing is S wave. S wave, there will be regression of the S waves. V1 S wave will be prominent, whereas in V6 S1 will be shorter. So so there will be S wave regression, PR progression, QRS duration should be less than 0.12, that is less than 3 small boxes should be there. And one more is Q waves. We cannot see Q waves in all the leads, and if Q waves are there, you should know whether it is normal Q wave or pathological Q wave. Q waves usually normal means less than, depth should be less than 2 small boxes, less than 2 small boxes, that is normal Q wave may be there, or sometimes we may not notice. But when the depth of the Q waves is more than 2 mm or more than 2 small boxes, we call it as pathological Q waves. That indicates that we can see in evolved or old MI, myocardial infarctions. What is the importance of this QRS complex? By assessing the waves duration of the width or duration of the QRS complex, R wave progression, S wave progression, we can make out hypertrophy of the heart, RVH, or right ventricular hypertrophy, left ventricular hypertrophy, sometimes bundle branch blocks, arrhythmias, and evolved or myocardial infarction. All these things can be assessed by QRS complex. Next one is the ST segment. So normal ST segment, usually there will be at the baseline, this region, ST segment is at the baseline. That is beginning of, end of the S wave to the beginning of T wave, that duration we call it as ST segment, that is very important. So causes for ST elevation, causes for ST depression. So if the ST segment is above the baseline, we call it as ST elevation. If the ST segment is below the baseline, we call it as ST depression. So ST segment elevation we see in acute myocardial infarction, left bundle branch block, pericarditis, whereas ST depression we see in myocardial ischemia, digoxin effect, ventricular hypertrophy, and other causes. So this is what I told about ST elevation. So you can see here ST segment, this region, this is at the baseline. But in second wave you can see the baseline is here, but ST segment is above the baseline, that is ST elevation. In third diagram also you can see the ST elevation. In fourth there will be slight elevation, but fifth it is normal. So this is about ST segment. Here one more thing you should note down is Q waves. See the Q waves here, it is 1 small box in depth, that is normal. Whereas you see here, it is more than 2 small boxes, that is called pathological Q wave. So this is normal ECG wave. Here you can see the ST segment elevation. Here you see ST segment elevation with pathological Q waves. Here you see pathological Q wave with ST depression. Here you see pathological Q wave with only pathological Q wave. So here the diagram A represents normal. In diagram B it represents anterior wall MI, acute myocardial infarction. In C and D it represents the evolved MI. E only pathological Q wave, rest all normal, that is called old MI. That is the progression of the ST segment in myocardial infarction. So T waves are usually followed by QRS complex, and the amplitude of the normal Q waves, T waves will be less than R wave. But here if the T waves are flat or inverted, that we can see in ischemia, hypertrophy, drugs, IV conduction delay, electrolyte disturbances, we see the flat or inverted T wave. Whereas tall T waves, that means T waves are larger than R wave amplitude, that we can see in hyperkalemia, hyperacute MI, left bundle branch block. So this is the ECG wave which represents ST segment, QRS complex and ST segment. Here you see about ST elevation. See here ST elevation is at the ST segment is in baseline, whereas here ST segment is elevated. Whereas here ST depression. So ST segment is below the baseline. Here ST segment is above the baseline. See the T waves. T waves which are followed by R wave which are less than R wave amplitude. This is T wave. Here see flattened T waves. You cannot see T wave. It is merged in the baseline. Whereas here inverted T wave. T waves are negative, that is inverted. These are abnormalities of the T and ST elevation and depression. See the pathological Q waves. Here Q wave this is normal. Whereas see this Q waves are more than 2 small boxes or more than 2 mm in depth. That we call pathological Q waves. So these are the STT changes. So this is the overall normal ECG. Before assessing the parameters, I will tell one more thing. I told about technical error. So usually whenever the person recording ECG leads, if they misplace the leads, how to make out whether it is technical error? By assessing the ECG, we can make out and ask them to re-record. How to make out? See all the leads, 1, 2, 3, AVR, AVL, AVF and V6. So here among all the leads, AVR is negative. This is the normal ECG. AVR is negative, rest all are positive. If the AVR is positive and 1 and AVL are negative, that means there is a misplacement of leads, except when there is dextrocardia. So in dextrocardia normally we get that pattern. Otherwise in normal individuals AVR will be negative, rest all positive normally. But if AVR is positive, 1 and AVL are negative, that means there will be technical error, there is a misplacement of leads. So this is the normal ECG. See the rate, RR interval, the number of boxes are, big boxes are 5. So 300 divided by 5, our rate is around 60. Rhythm, you can see the RR interval is same in between all the waves. That is rhythm is regular. See the P waves, can make out small. P waves are there in almost all leads. Then QRS complex, the duration is less than 3 small boxes. You see this V1 to V6, R wave keep on progressing, that is R wave progression is there. S wave, the size of the R wave decreases as you go from V1 to V6. So R wave progression, S wave regression, QRS duration is less than 0.12, so that is normal QRS. Then followed by T wave. T waves are less than amplitude of the R wave and it is positive waves. So T wave is normal. So this is about complete normal ECG. The rate, rhythm, regularity, P waves, all the waves are normal. We call it as normal sinus rhythm. So rest of the ECG abnormal disorders we can assess are arrhythmias, heart blocks and ischemic heart disease. They will be told by my friend Dr. Vinay. I will end my talk with this last ECG. This is the most easiest ECG to diagnose but difficult to explain. So this is called sinus arrest. So I thank all the organizing committee of Dental College for this opportunity. I am handing over to Dr. Vinay. Thank you one and all.
Thank you, Sandeep sir. You have made my job easy. Now, moving to the abnormal ECG. The word abnormal usually comes with the chaos, anxiety, and then there's like this is something deviated from the normal one. All this time you understood what the normal ECG looks like. Now let me go through the abnormal ECGs. This is quite difficult, but let me make it easier. Okay. So I think everyone have got a handouts. Worksheets are there. Now through that I will discuss the ECG so that it will be much more like easy to understand, and then you have that handouts to carry to a home. Now that's what we understood now, how the normal ECG looks like. This is not given in the worksheet. Okay. Always you can read the ECG based on the certain parameters like rate, rhythm, and then look at the waves and all. Okay. So now in this normal ECG you understand that how to calculate the rate. Okay. Now you know that big boxes, that means the number of big boxes which is there in between the RR interval, that always is the RR interval. In between that, how many large boxes are seen? Now it is 3. 3 large boxes are seen in between the RR interval. Okay, now we use a certain numbers. Here 300, use the word 300. 300 divided by number of large boxes gives the rate. So here it should be 3 large boxes are there in between the RR intervals. So 300 divided by 3, it should be 100. So is it regular? Yes, it is regular. Every P wave is regularly placed, and every R is regularly placed. This is regular. So that's how normal ECG looks like. And P wave is normal. The small hump in just before the QRS complex is the P wave. PR interval, that is also normal. PR interval means that from the starting of the P wave to the R, that should be within the one large box. So it is there within that. So that is normal. QRS duration, if it is occupying less than 3 small boxes, then it is normal. Okay, so this is a normal sinus rhythm. Henceforth, I call this rhythm as NSR, normal sinus rhythm. Okay, and then let's move to the abnormals. First, we'll discuss about arrhythmias. Arrhythmias means something out of the rhythm, arrhythmia. So we have got the rhythmical disorders. So first ECG, which is given in your handouts. Okay, no need to look at that because that's the gyroscopy, so it's not that visible. You can look at the screen. So here you can look out what is happening here. The RR interval is not regularly placed. Somewhere over here it is very short, and then the just next to that is it has got a big gap here, and this is a irregular one. Now look at the rates. So now sir said you can't calculate rhythm rate over here because it is not a regular ECG. So over here what we do is we take a ECG for 6 seconds. So this entire strip is for 6 seconds. So now calculate how many R waves are there in this total strip. How many are there? 10, okay. 10 into 10. 6 into 10 gives us 60 seconds. So 10 waves are there into 10. 100. Regularity? It's not regular. Okay, irregularly irregular. Okay, so P waves, are there any P waves now? So actually over here, there is a baseline disturbance here, but actually there are no P waves. This you can't consider. P waves are not having the same morphology. So this is not a P waves actually. This is because P waves represent a atrial activity. If atria is not contracting, if atria is not stimulated or not depolarized, this gives rise to a baseline disturbance. Okay, and that we can't consider it as a P waves. So absence of P waves, there are no P waves over here. PR interval, since there are no P waves, you can't say what is PR interval. So you can't decide it. QRS duration, it is narrow. Okay, that means this is occupying less than 3 small boxes. Okay, so it's a narrow QRS complex. That means the impulse is coming from the conduction system. If QRS complex is quite wider, that means impulse is generating out of the conduction system. That means it is coming from the muscle tissue. So especially if it occurs anywhere in the ventricles, it gives us a wide QRS complex. That means more than 3 small boxes. Now this is within 3 small boxes. That means it is coming from the conduction tissue only, but not from the anywhere else. So that means it is happening there, but over here, atria is not contracting. Atria is not getting stimulated. Okay, it is just fibrillating. It is not contracting. That's why we call it as a atrial fibrillation. So how it deviates from the normal sinus rhythm? There is no atrial deviation, that is no P waves. Atrial activity is chaotic. And second thing is it's a irregular rhythm. And it is quite common to see in patients above 80 years old. And in young patients, it is not that common. Okay, coming to the second ECG. Now, can you see any changes in the regularity? It is regular. It is regular. Okay. Okay, what is the rate now? Now we can calculate it. Between RI intervals, how many big boxes are there? Close to 1, 2, 3, 4. 4 big boxes. So 300 by 4. Close to 75. Regularity. Is it regular? Yes. P waves are there? Yes, they are seen. So everything over here, no, there are P waves actually. But there are multiple P waves. So over here, when there are multiple P waves, you can't correlate on the PR interval, because which P wave to consider? So you can't comment on the PR interval. But look at the QRS. QRS is narrow, so it is normal. So that is coming from the conduction system itself. But over here, there are multiple P waves. This occurs in case of a atrial flutter. Okay, so this is almost akin, similar to atrial fibrillation. But thing is that over here you can see the P waves. So this is called a sawtooth P waves, sawtooth pattern. If that is seen in any ECG, you can always say that this patient is having a atrial flutter. Now coming to the third example. Here, is it regular? Yeah, initially it is regularly placed. But later on, after fourth, fifth beat, so you can see that it has gone faster. Regular, still it is regular, but it is quite faster compared to the previous one. Okay, let's decipher it out. Okay, one is rate. So initially it was 74. 4 big boxes. So 300 divided by 4, 74, 75. So over here, it is close to 2 big boxes. So 300 divided by 2, it will be almost close to the 150, approximately. So rate has moved from 74 to 150 close to. Regularity, yes, it is regular to the regular itself. P waves, yes, there are. Okay, but later on, there are no P waves later on. Okay, this is a P wave, this is a P wave, this is a P wave, but later on it is not there. Okay, so PR interval. So initially it was regular, later on it was not. There is no P waves, you can comment on the PR interval. QRS duration, yes, it is narrow. See, QRS has not changed any morphology here. Previous also it is the same, now also it is the same. So the PR interval, QRS duration is normal. So this is something called as paroxysmal supraventricular tachycardia. So paroxysm means it is sudden onset. Suddenly it is like normally it was normal and suddenly it went up to that. Okay, so paroxysmal supraventricular. Why I say it is supraventricular? Because QRS duration is normal. It is narrow. Whenever it is narrow, that means it is coming above the ventricles. So supraventricular, above the ventricles, tachycardia, faster heart rate. How does it deviate from normal sinus rhythm? It suddenly speeds up. Is often triggered by a atrial complexes. Okay, that's not seen here, and then and that leads to a loss of P waves. So now coming to the fourth example, which is given in your handouts, you can see this ECG. What is happening here? There are no P waves, and these are called actually QRS complexes. They have different morphology. Okay, here the QRS is inverted. Okay, and it is wide. Okay, it is wide. So it still is considered as a QRS complex itself, but it is inverted and it is wide. That means whenever I said like that, this is wide, that means it's coming from the muscle tissue, not coming from the conduction system. So this is occurring in a ventricle itself. Okay, so let's decipher it out. Rate, you can say that between RR interval, there are approximately close to 2 big boxes, 300 divided by 2, close to 150. Regularity, it is regular. Okay, and in P waves, no P waves seen. That means this activity is not generating from the atria. If atria is involved, P waves will come. Okay, so then there is no P waves, no chance of PR interval, and in QRS duration, it is wide. More than 3 big boxes, it is wide actually. So that this means this is coming from the ventricle. Okay, and then there is a tachycardia too, more than 100 beats per minute. So this is a VT, ventricular tachycardia. Okay, this is an emergency condition. Okay, why? Because this doesn't allow the heart to relax properly, and it doesn't get filled. It doesn't put out the volume. So BP may go down. Patients may ultimately turn up into like if you don't act, they will have the difficulty to their life. So impulse is originating from the ventricles, and there are no P waves, no QRS. We have to treat them immediately. So one more ECG. Now coming to the other one. This is given there. Okay, what you can consider here? Previously it was a regular waves. So now there are waves here. you can consider them as a QRS waves, but they are not regular. They have got a different morphology. Okay, this is nothing but a ventricular fibrillation. Over here, there is no contraction of the ventricles, it just fibrillates. It just fibrillates, that means there is no contraction. This usually we won't see. Whenever it occurs in ICU or when the patient, when you're doing a CPR, almost on the deathbed. Okay. So almost when the patient is on the verge of, at the time of death, then you get to see this. There is no ventricular activity. Okay. That is done. This is a very dangerous condition. This you won't normally see. Okay. Fine. So this is about arrhythmias. And one more we missed out is the ECG number 6. Before this, there are actually other ECGs are there, but for the sake of because we have less time, I have only put out this last ECG because it's very easy to decipher out. Can you see what is happening to regularity, rhythm? It is regular, right? This is QRS complex. QRS complex, it is each one are regularly placed, and there are P waves, they are also regularly placed. Okay, let's decipher it out. Rate, I said you have to calculate the RI interval, okay, not the PPU intervals. So you can see how many big boxes are there in between. 1, 2, 3, 4, 5, 6, 7, 8. Okay, 300 divided by 8, close to 40. Okay, so regularity, it is regular. P waves, yes, they are seen. So you can see that now all the P waves are there. Okay, and they are coming regularly. But can you correlate with the R waves, QRS complex? It is not so. Which wave to consider? So PR interval, you can't comment on that. QRS duration, what is happening to QRS duration? Is it wide? From here to here, it's wide. Okay, so that means it is not coming from the conduction system itself. It is coming from the ventricles. Okay, that's why it is wide. Okay, this ECG looks like we have got a regular P waves, we have got a regular RR interval. Okay, but there is no connection between these two. P waves are beating on their own when QRS complex is coming on their own. So there is no connection between the P waves and then QRS complex. That means there is a cutoff. So ventricles are beating on their own. Atria is beating on their own. Okay, so this is like two ECGs of P waves and then QRS complex are superimposed together. So this is a conduction block, complete conduction block. That means there is a complete, like an atria is beating on its own and the ventricle is beating on its own. This is also a rare condition to get. So these are the examples of arrhythmias which you have put out there. So how does it differ from normal sinus rhythm? Same as that. Okay. Okay. After this, one more intriguing abnormal ECGs are MIs. Coronary artery diseases. It comes in two varieties. Like one is ischemia, where the blood supply to the heart itself is decreased. So there is that is called ischemia. And then when it is completely cut off, that is called infarction. When there is a ischemia, when the blood supply to the heart is decreased, you get to see the T wave inverted and then ST segment depressed. This we have seen this before, how the normal ECG looks like. And in case of myocardial infarction, when the tissue is infarcted, when the tissue is totally cut off with the blood supply, you will get either ST segment elevation or T wave inversion or Q waves later. Initially we will get to see the ST segment variations, later it will be T waves, later it will be a formation of Q waves. So where do you see ST elevation? ST elevation should be there in the two contiguous slits. That means if the ST elevation is there V1, ST elevation should also be there in the V2 or V3. If it coming contiguously, that means continuously, then you can say there is something definite problem is happening in that ECG. If it is coming in one lead and then if it is not seen in another lead, then it is not so. Okay. So what is the criteria to say whether this is ST elevation or not? If there is an elevation in 1 mm from the baseline, then it is significant in all if it happens in all the leads. But there is an exception to that. In V1, V2, they should be more than 2 mm, because normally you can see 1 mm elevation in V1 and V2. Only except that in anywhere else, if there is a even slight elevated ST segment from the baseline, then you can say that the patient is having a MI. This is a basic thing you have to know. So this is a sequence of MI. Just now we discussed this before, like Sandeep sir did it. So that's how the normal ECG looks like. If in acute MI state, what happens is that this is the ST segment. It should be over here. Now you can see that that is elevated. This is called tombstone appearance. Okay. So whenever this is there, that means there is a patient is having a MI. Okay. Then what happens is that this segment slightly comes back to the normal stage after some time, maybe after 1 or 2 hours. So what will happen is T wave starts getting inverted. Okay. And then later this will come back to normal stage, but you can see that now there is appearance of Q waves. Whenever there is appearance of Q waves, that means the tissue is gone. It's infarcted, it's gone. Okay. So it is not a viable tissue. So whatever the necessary steps we can take, so whenever the MI we give treatment, no, that should be done in this stage so that we can prevent a tissue loss. If it is already Q waves are come, that means it is evolved. There is whatever the medications or interventions we try, still there will be of no use. Okay. So whenever there is a MI, we can say which wall is involved based on the changes in the leads. Okay. So we have the walls of the heart. This is the inferior, anteroseptal, lateral, and then anterior and posterior walls. Okay. How do you know which wall is involved? So for example, if there is a lead 3 and then lead 2 which represent the inferior side, if they are showing changes, that means something is happening in the inferior wall. To diagnose the anterior wall MI, that we use a chest wall leads. So when the ECG is placed on V1, V2, that's in the anterior chest leads, if the changes are seen in V1, V2, V3, V4 in the anterior part, so that is the anterior wall MI. If the changes are also seen in the lateral parts, V5, V6, and also in the limb leads, especially the lead 1 and AVL, that means it is a lateral MI, anterolateral wall MI. If the changes are seen in the lead 2, there's a limb leads, lead 2, lead 3, and then AVF, that means it's the foot. If the changes are there, that means there is a inferior wall MI. We'll understand this one. So here the ST elevation looks like this. So here okay. I hope this ECG is given in your handouts. Look at this ECG. Let's understand what is happening here. Is it there? No. Okay. It's there. Okay, good. Okay. Okay. So look at the QRS complex. QRS complex is slightly wider. Okay. And it is regular too. It is regular. It is coming regularly. Okay. And there are P waves. P waves are there. In every QRS complex is preceded by a P wave that is there. And then let's look at the T waves. Look at here. One T wave is inverted. T wave should be upright. It is going down now. So T wave is inverted. Same thing in AVL, it is inverted. These two go hand in hand. 1 and AVL always go hand in hand. So that means whenever there are changes in the 1, you can expect the same change in the AVL 2. Whenever, okay, and then this is paired, and then over here, lead 3 and AVF is always actually paired. That means whatever changes you expect in a lead 3, that should be same in case of AVF 2. This is a paired way actually. Okay. But here onwards, it is not so. These are called chest leads. So V1, V2, V3, they are all depending on the placements. Okay. So over here, you can see that the T wave is inverted in 1, T wave is in AVL. Okay. And then anywhere else, T wave is inverted in V4, V5, V6. Okay. Now, apart from that, let's look at the ST segment. There is a depression there. ST segment is depressed in V1, lead 1, AVL. Okay, and also in V5, V6. But that is not significant for us because we have got something more significant over here. That is the ST elevation. You can see that, no? This is elevated from the baseline. I said ST elevation in other leads, even if it is 0.1 mm, it's significant. But that is exception is only the V1 and V2. It should be more than 2 mm. Here it is more than 2 mm. V1, V2. Here is the ST elevation is more than 2 mm. Okay. This means patient is having an MI. That is this V1 and V2 is placed anteriorly. This is a anterior wall MI. That case. Okay. Anterior wall MI, and whatever changes we getting here now, T wave insertions, these are actually reciprocal changes which you get opposite side of this. Okay, lateral side and inferior side and all you will get is the reciprocal changes. And over here, anything wrong in the ECG? Look at the rate and rhythm. I think they are regularly placed. Okay, the rhythm is fine. And look at the QRS. This is narrow. Look at P waves are there in the preceding all the waves. Okay, what is abnormal over here is, look at here, there is slight ST elevation in the lead 2, same thing in the lead 3, same thing in the AVF. I said whenever there is a changes in the lead 3, the same thing should be seen in AVF. So there is ST elevation in lead 3, ST elevation in AVF. That means these two leads always look from below. They are looking at the changes happening in the inferior wall. So this is actually a inferior wall MI. So ST elevation is there. This is an inferior wall MI. Examples I'm just giving that. Okay. Lead 2, 3 and AVF. There is an inferior wall MI. Okay. It is obvious now. What is happening here? So there is ST elevation. There's a quite stark. Okay. But let's decipher it out. So this is a regular ECG. There is no arrhythmias here. Regularly placed. Look at the QRS complex. This is narrow. Okay, and there are P waves over in all the leads. So P waves, QRS complex, T wave, everything is almost fine. But look at what is happening to the ST segment. Elevated from the baseline. Lead 1 elevated, AVL elevated, and it is very strikingly elevated in V2, V3, V4, V1, V5. Okay, and slightly in the V6. So this is a continuous one. It's like ST elevation start from V2 and it is up to V6, and also it is over here in the lead 1 and an AVL. I said no, this two go hand in hand. Okay, so this is a ST elevation MI almost extensively from V2 to lateral leads. So this is a case of anterolateral MI, myocardial infarction. But along with this, what you can see here is there are Q waves too. Q waves. This should be upright like this, but this is depressed. This shows that tissue is infarcted. Okay, it is already evolved MI. Okay. This is there at the back of your sheets. This is to understand now, after knowing the basics. This is for actually for the PGs and all, but there is a lot of learning over here also. So, this is a 17-year-old boy has noticed the high heart rate in his Apple Watch. Then you take an ECG, then you find out an ECG like this. So can you guys read this? So is it regularly placed? There is no rhythmical disorders. It's regularly placed. Fine. P waves are there. Yes, there are P waves. Every lead has got a P wave. And then QRS complex, slightly wider, but it is in the normal range itself. Maybe less than 0.12 second. That means less than 3 boxes. But look at the T waves. What is happening to the T waves? T waves are inverted in lead 2, lead 3, AVF, and in the lateral leads over here, V4, V5, V6. Plus, along with there is a ST depression. The point over here is, this is quite a difficult one. Point over here is, there is a short PR interval. P wave came, and immediately after that there is a QRS complex. Okay, this is an abnormal one. Actually, there should be a gap. There should be a proper gap, at least a one big box between the P wave and QRS complex. So this gap is shortened because this ECG, in this ECG, the impulse is not traversing through the AV node. See, SA node will be there upright, and then there is a AV node, and then after comes the bundle of his and everything. AV node, what does it does is, it delays the conduction. AV node, it comes in between, it delays the conduction so that there is a certain gap between the atrial contraction and the ventricular contraction. Okay, so over here, something is happening, that means AV node is not functioning, that means there is some bypass procedure is there, bypass conduction system is there. Whatever the impulse which is generated from the SA node, it is coming directly into the ventricles, not bypassing the AV node. This happens in case of a extra tissue connecting between the atria and ventricles. This is a very, very typical of, heard of WPW syndrome? It's called Wolff-Parkinson's White syndrome, where there is a extra conduction system between the atria and ventricles that will bypass the AV node. So this is quite a rare one. So in these patients, there will be a, sometimes they may say, complain of palpitations, sometimes even they say about, tachycardia will be there, those things will be there. Okay. Wolff-Parkinson White syndrome. The one more thing is that PR interval, QRS complex is slightly wider. That is because the ventricles are excited through other pathway. If it is coming from the conduction system itself, it would have been narrow. Okay. Coming to the ECG 2, a 30-year-old man coming with the palpitations. Over here, when you take an ECG, the findings are like this. So in those advanced ECG need not be telling all the findings, but you get to know that what can go wrong. Okay, just by reading a just like a normal ECG. Over here, what is wrong here? Is it regularly placed? Yes, they are regularly placed. QRS complexes, it is narrow. P waves are there. Even T waves are there. In certain points, T wave is inverted. Where it is inverted, in lead 2, lead 3, AVF, this is inferior lead, plus V1, V2, V3, V4, V5, V6 also. In all the leads, in the chest leads, it is inverted, plus in the inferior leads, it is also inverted. But catching point over here is something happening beyond QRS complex. So there is a small bump here. It is coming after the QRS complex. This is called epsilon waves. Okay, this is a rare entity. I don't think so. You should be going through this. But just for your information, I'm telling this. This is something related to right ventricular dysplasia, because in the right ventricle, it is dilated. It is arrhythmogenic. Okay, and that leads to inversion in T waves, especially in the anterior chest leads. So this is actually arrhythmogenic right ventricular dysplasia, not required for you people, but understand that how to decipher out an ECG. And then coming to the other one, so a 53-year-old male patient with left shoulder pain and diaphoresis. This is a case of typical MI. That means when the chest pain comes, that is radiating to certain parts of the body, especially the neck, shoulders, back. And then if they come with palpitations and if they come with diaphoresis means sweating. If that is there, and then you take a ECG, and then can you decipher out what's wrong here? Is it regular? All the beats are coming in a regular interval. Is there a P wave? P waves are there. And then look at the QRS complex, that is narrow. And then what is happening to the T waves? T waves are there everywhere. But look at the ST segment. ST segment is depressed. Okay, so in V2, V3, V4, V5, ST segment is depressed. It is below the baseline. And other than that, everywhere else, in the V1 and then V1 also, in lead 1 also there is a segment depression is there, but it is not happening in the AVL. So we can consider it. But over here in the chest leads, ST segment is depressed. Since there is a sweating, since there is a pain, we have to evaluate these patients. Though there is no ST elevation, ST depression is over here. So when you check out tropi, which is the enzyme which gets elevated, okay, in case of MI, and when you check out, when you take a echo, there will be a motion wall abnormalities. This is actually a case of a rare incidence where you get a posterior wall MIs. Over here, anteriorly there is no ST elevations, but when you take the ECGs beyond V6, V6 is in the posterior axillary line. So there's something beyond this, something in the axilla, in the posterior part of the chest. If you take an ECG, there you can find a ST elevation. So this is actually a posterior wall, a case of posterior wall MI. This is also a rare condition to occur. Okay, and this is a classical ECG with MI. What is happening here? there is a ST elevation in lead V2, V3, V4, V5, V6 like this. And ST elevation, okay, over there, over here itself. This is actually a case of anterolateral wall MI. Okay. Let's stop at this. And before concluding, I have certain take-home points. One is ECG, though it looks tough, it is easy, only if you know the basics right. Second thing, you should not shy away from glancing at every ECG. So you should be looking at every ECG as possible, and then each ECG will be having a learning point in it. Never miss an opportunity to learn, even if you're an expert in ECG. And then we know that through ECG we can diagnose MIs, but not all MIs will have a ECG changes. So that means ECG can be normal in 15 to 20% of the cases. So always back up with your investigations. You can do investigations like the echo, you can do prop eye and all. And then ECG can be abnormal in 25 to 30% of the cases, but the patient will be normal. So not every abnormal has got findings. Not every abnormal ECG should be evaluated further. Okay, this thing is there. In cases of doubt, always have a second opinion. Okay, we are the physicians, cardiologists, everyone are there in the campus itself. You can always take an opinion from them. And then sometimes even the non-cardiac phenomenon. So ECG doesn't mean that always it's related to heart. Something other than the heart, they will have some changes other than the heart, like especially the electrolytes. Sometimes in the intracranial bleeds, raised intracranial pressures will have an effect on it. So this is how it looks like. These are electrolyte changes. That means that if the potassium is low, hypokalemia can have changes like this. T wave will get inverted. Hyperkalemia, T waves may go up. Hypokalemia, these changes will be seen. And similar to that, if there is an intracranial pathologies, if there is a right intracranial tension, you can see that how the T wave looks like. This is not related to cardia, but that ECG will show changes. This is something related to the brain, but still ECG will have changes. And also in some case of poisonings, TCAs, tricyclic antidepressants, that means amitriptyline and all, can have changes like this. Okay, fine. With that, I would like to conclude my topic. I would like to thank organizing committee of Dental College for giving me an opportunity. Thank you, Nando. Any questions? Anyway, ECG is a complex topic, as I did before. Sure. I know, sir.
Thank you, sir, for this educative workshop. Now I request Dr. Murli Mohan sir and Dr. Hiremat sir to give away the certificates to Dr. Vinay and Dr. Sandeep sir. Now I request Dr. Vijay Lakshmi ma'am to talk a few words.
Good afternoon all. I am taking this small opportunity to reach all of you on behalf of B.K. Venkatraman Centenary Celebration Committee. This was a brainchild of our senior professor and stalwart, Dr. Nagesh, Dr. C.V. Mohan and Dr. K.S. Ganpati sir. We have made the committee, and to have a valedictory function of BKV birth centenary celebration, which is going across for an year, is going to have its final function at GDCRI Bangalore, and it is planned to be at GDC on October 26, 2024. And today it is a very heart-touching moment to all of us to see a lot of Dr. BKV students who are gathered here And the big drive is Dr. BKV sir's relationship or his mentorship to his students. And we don't want to miss you all out for a program at GDCRI. So I take this opportunity to welcome you all to the valedictory function. Kindly register, and the registration is open now. So I request once again, all of you shall kindly participate. And this is a e-brochure we have released on this occasion, and there are various committee, and we will be circulating it shortly among all the among the dental fraternity. And we have conducted several programs, and as we have been telling from morning, this is the 5th program, and there are various subcommittees which has been made in various institutions who have participated, and the valedictory is in GDCRI. Please, all of you are invited, and please register and participate. It will be a great moment for all of us, and let us all cherish Dr. BKV sir. Thank you, Anand.
Thank you, ma'am. Now I request Dr. Bharatesh sir, HOD Department of Public Health Dentistry, to deliver the vote of thanks.
Cicero, one of the greatest Roman philosophers we know today, quoted, I quote, gratitude is not only the greatest virtue, but the parent of all virtues, unquote. And this is what we have tried explicitly expressed from morning to one of the legendary teachers in our fields. Good afternoon, ladies and gentlemen. I deem it an honor to deliver today's vote of thanks on this memorable occasion. I humbly remember and acknowledge our founder, Sikshana Bhishma, Dr. H.M. Gangadharaya, whose vision and commitment go beyond words. I humbly remember and acknowledge our director and founder, Chancellor, late Dr. G. Shivprasad sir, for all his contributions towards the college and the society. I extend my heartfelt thanks to our Honorable Chancellor and Home Minister, Government of Karnataka, for his constant motivation, guidance and support in his absentia. I thank our Vice Chancellor, Dr. B.K. Lingegowda sir, who is always there supporting in all our endeavors. Dr. M.Z. Kurian sir, for his constant guidance, and Controller of Examinations, Dr. Guru Shankar, for all his support. I extend warm regards and thanks to our guest speakers of today, Dr. B.V. Murli Mohan sir, Dr. R. Suresh Kumar, Dr. Sandeep and Dr. Vinay for their wonderful and knowledgeable talk on various intriguing topics. I extend my regards to all the principals, vice principals, associate deans, medical superintendents, HODs, teaching staff of all the colleges for their wholehearted support and cooperation. My heartfelt thanks to all the members of Dr. B.K. Venkatraman Birth Centenary Committee and Government Dental College and Research Center, Bengaluru, Alumni Association, who have initiated, spearheaded, and overlooked the programs in various colleges all over the states. Thank you, sir. I acknowledge the presence of staff members from other colleges, senior professors. Thank you for your active participation. Special thanks to Sri Siddhartha Dental College Alumni Association, President and Vice President Dr. Naglakshmi Chowdhury, and all the official office bearers and members of alumni of Sri Siddhartha Dental College, and the special thanks to the first batch students who were the And a special thanks to all the first batch students who were the students of the great teacher, students of the great teacher. My regards to all the other members of the committee other than the alumni who have worked really hard for the success of the event. My special thanks to all the volunteers for their kind and active participation to make the event a grand success. Special thanks to Mr. Muddesh, Director of Media Studies, for arranging the live streaming of the program. Last but not the least, my heartfelt thanks and regards to my dear students for their active participation. I think it as a duty, before I end, I would again like to acknowledge the efforts of our principal, Dr. Praveen Kudwa, and the team for their untiring efforts in making the program a grand success. Thank you for your patience. I have a small announcement. The hostelites are required to report to the central kitchen for the lunch. Thank you.
Thank you, sir. Now I request everyone to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य